Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 4 conversations from episode 57, our introduction to the Liver Forum with Executive Director Veronica Miller and our longtime friend Manal Abdul-Malik, plus Marvault, a conversation from Season 2, Episode 50. The web page from Season 2 that was viewed most often in the last 3 months by our listeners and downloaders. This week's Vault conversation comes from Season 2, Episode 50.2 with Antaro's Medical Chief Scientific Officer Lars Johansson asking why we spend so much time focusing on what shouldn't be happening in the liver as compared to what should be when the liver works right. As one example, he discusses the use of gadolinium contrast agents, which can enable researchers to combine dynamic liver function measures based on hepatocyte function with static measures based on liver stiffness and PDFF. Stephen Harrison spends the rest of the conversation discussing the benefits such an approach can bring to clinical trials and drug development. Season 2, Episode 50 is one of our most downloaded episodes, despite the fact that our listener base now is roughly twice what it was back then. So you should sit back, listen, enjoy, learn, and then join the conversation in our LinkedIn discussion group.
Louise Campbell.
Louise, what you thinking?
I was just fascinated by listening to all. I didn't go to Paris NASH, sadly, but it potentially offers a really valuable opportunity to move beyond liver biopsy eventually. The imaging techniques, the ability to monitor liver tissue and its components and changes becomes a real reality that biopsy doesn't offer us because people don't want to do too many serial biopsies. It allows us potentially to look at the long-term effects of all these medications, of changes to people's histology and liver condition over time, irrespective of whether or not it would be a pharmacological agent. If we do lifestyle monitoring, these techniques, if they become real and we can monitor that change, it offers us to be able to monitor all those changes in individuals, no matter what the solution is we choose, to see how effective it is. And some will suit others more than others. And I suppose that's, for me, anything that reduces a patient's need to undergo biopsy and any therapy of assessment that causes side effects that put people at risk is absolutely fantastic.
Lars Johansson.
I think you bring up another important piece there, Louise. As you said, with histology, we can only get that far in assessing the functional aspects. And that was the second piece I talked about in Paris, is to use, and this is something which has been around for a while, and we have Paul Hawkins at Antaros, who's been pioneering some of this work, using gadolinium contrast agent, gadoxetate, or gadoxetic acid, which is to at least 50% of its biodistribution is taken up by the hepatocytes. And we are so stuck on, because the definition of disease is by biopsy, that's how you define NASH, but we are so stuck on imaging everything that shouldn't be in the liver that we kind of forget what should be in the liver, and that's functioning hepatocytes. So that's the other part was talking about, and that's where we already are running clinical trials using this gadolinium contrast agent. So you put patients in the MRI, you do the PDFFs, you do the MRE, but you can add these contrast agents to also assess liver function. And it's actually not that difficult. And I think there's some really nice papers out there also on the prognostic value of these tests, showing that how gadolinium uptake predicts transplant-free survival and time to decompensation in compensated cirrhosis. That's an avenue where you can combine both the static assessment of stiffness and PDFF, etc., with the functional assessment of the liver. So I think that's very exciting for the future.
One of my particular fascinations personally is the whole idea of dynamic systems. And one of my real frustrations when I got involved a couple of years ago with fatty liver was that by definition, histopathology and biopsy is a very, very static read. You get one small slice, you get it only on a couple of occasions. What you're talking about here, and after Stephen's answer, I'm going to create a section I'm calling Dare to Dream. We'll come back to it. But what you're describing is the ability to use imaging to capture all the dynamics of the liver at multiple different levels. I mean, not all, but a significant capture of the dynamic of the liver, which makes everything we're doing infinitely more efficient because we actually know where the target is and how it morphs.
Yeah, I think you're right. And I think it's really a fundamental thing when you think about it conceptually that, the liver has a fantastic capacity to regenerate. And when that doesn't happen anymore, obviously that's when you start to get in trouble. And that's why I think the number of functioning hepatocytes is a very good marker. And I think that's also why it has such strong predictive value of future outcome. If you have have very few functioning hepatocytes, you are in much worse situation. That doesn't mean that it still has a clinical manifestation in terms of decompensation. You may even be at the subclinical situation, but I think that's why it has such strong prognostic value.
Stephen, come back on the comment that Lars was asking about, but then I'd like you to lead us into a section that I hadn't planned on called Dare to Dream, which is what kinds of vistas can you see, you first and then all of us, see opening up from what Lars is describing? And Lars, what I'd like you to lend to that is you mentioned other areas, subclinical, we haven't even commented on yet. So if Stephen could talk a little bit about Dare to Dream and Louise could, and then you could give us a flavor, and maybe me, depending if we have time, give us a flavor of what's out there, what's coming, what does the future promise that'll make us even better equipped to deal with these issues and create therapies and approaches that work. I think that would be just a really enlightening and helpful thing for this audience. Stephen, go ahead.
Well, I think this is a huge area for the field, not just for NASH, but in liver disease for sure, and maybe other diseases. Functional assessment has been a challenge. We've historically done hepatic venous pressure gradient monitoring, which if you've never seen one of those procedures, it's pretty invasive. It's very invasive. You're going through a large vein in the neck and patients have to be still. You're basically measuring pressure gradients around the level of the heart, the bigger veins heading into the liver. It's a complicated process and there is significant potential for variability. Patients breathe. If patients bear down, you can change the outcome of an HVPG reading. So it's best done in centers of excellence where they do many of them. And it's also very, very costly. So what else is there? Well, we have a couple assessments that could be done that are blood-based, but these involve putting 2 IVs in patients and giving cholate and measuring it over a 3-hour period of time and getting at the functionality of the liver. That's called HepQuant, and we're doing that in some of our clinical trials now. And the early data looks relatively promising with that technique, but again, it takes a lot of time to do. It involves quite a bit of manpower and patients on the patient's behest and at least 2 functional veins that could be tapped with IVs. So we need something that is a little bit more holistic, that can tell us a little bit more about what's happening functionally with the liver. And to do so with a technique that Lars has mentioned opens up a huge opportunity to assess liver function in a much more easy fashion and more readily acceptable by patients. Now, the next step is how do we get this done in a manner that is efficient and that can advance the field relatively quickly? If you think about it, we have 2 MRI techniques currently that are working in this arena. One is MR elastography and the other one is multiparametric MRI, in the sense that with CT1 scores above 840, we know that's linked to a long-term negative outcome. Whether it's liver-related outcome or cardiovascular or something else, that type of granularity still needs to be delineated. And furthermore, the time period to decompensation is yet to be delineated. And is a score of 1,200 worse than a score of 840? And if so, by how much? We don't know those details yet. With MR elastography, with more data recently coming out from Alina Allen, we know that a KPA of 5 equates to a 20% chance of decompensating over 3 years. And if the MRE is 8 KPA, that it's 40% over 3 years. But that's kind of the extent of our knowledge with that right now. So could we fast forward here and ramp up our discovery of a drug and its ability to decrease or minimize outcome by using a technique such as this? And I think we absolutely can. That's probably one of the most exciting things I took away from that meeting. I knew it was out there, but I didn't know that it was already being used and that this is something that potentially we could incorporate into clinical trials now, at least in those where we're studying cirrhosis. Because to me, that's where we could really get after finding a niche in drug development for this device, for this imaging modality right now. What do you think, Lars? You agree with that? Or
I completely agree. If you go for really early NASH, it may not be that easy to separate. If you go to late stage or like F3, F4, it definitely can play a role there. I think it's nice, the papers that have been shown from Bastati in 2020, where they examined quite a large number of subjects and followed for 4 years. And it has very strong prognostic value on outcome. So in an F4 population, definitely in a cirrhosis population, this would make sense.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please send an email to questions@surfingnash.com. We'll be back next week, possibly with a preview episode for NASH, possibly with something else. We'll announce that later in the week. Until then, stay safe, surf on, and we'll see you on the podcast. Bye-bye now.